This lecture is going to cover the final couple parts of wound care for the PTA208 class. We're going to start talking about different types of wounds, specifically arterial wounds, pressure injuries, and stuff like that. First thing we're going to cover is arterial wounds. Arterial ulcers. What do you think causes arterial ulcers? Well, it happens when we get arterial insufficiency, right? So it's just a patient here. Patient enters clinic with leg pain of unknown etiology. Supervising PT wants you to do a quick test to rule out arterial venous insufficiency. He asks the patient to lay supine and elevate the limb, which would cause increased pain. Well, if the limb's getting elevated, obviously it's going to improve venous insufficiency. So that means that it's going to be arterial insufficiency. So any decrease in arterial blood supply results in ischemia. That ischemia there will then cause pain, and that leads to an arterial problem. Main causes obviously arteriosclerosis, atherosclerosis, any trauma or any embolus in the actual artery supply itself. So how can we test and check for insufficiency? Well, we can do pulses, right? We can look for pulse differentials, where maybe the pulse is different, closer to the body, more proximal than it is distal. We can check both legs, compare both legs. We can check both arms, compare both arms. If we notice any difference, that means there's going to be an arterial insufficiency somewhere. We can perform a Doppler ultrasound. Doppler ultrasound is going to tell us what's going on inside that leg. Typically, we're going to do the Doppler ultrasound if we suspect any type of clot or anything to that effect. The ABI is another one. Capillary refill test, where we're checking to see how long it takes for the blood to, when you press down, for it to go from blanching to full again. And then also venous filling time is another one we can do. So what can cause potential arterial ulceration? Well, obviously LDL cholesterol. So mainly thing here is they've got to manage their cholesterol. You guys should all know your cholesterol levels at this point. You're all at the point where you should be starting to keep an eye on that. Smoking. Hopefully none of you smoke. If you do, this puts you at risk for arterial ulcers. Actually puts you at risk for tons of things as well. Diabetes, right? Diabetes seems to cause all kinds of problems. It also tends to cause problems with the venous ulcers as well, so that one's a double-edged sword. Hypertension, any type of trauma, so anytime that you get a severe trauma to that injured leg especially, so say maybe you have already a compromised system in the left leg. If you actually go ahead and get additional trauma to that left leg, that can cause even further problems. And then as we advance in age, obviously, that's going to cause further problems. So we're going to look at the presentation of arterial wounds, and this comes from woundeducators.com. We're going to look at the 5 PT method, right? So pain, if it's extremely painful, that's a good sign of arterial wounds. Obviously, or most likely, venous wounds don't have as much pain. Position, it's rarely above the knee, right? It's usually down at the toes, the lateral malleus, anterior leg, anything to that effect. Presentation, they present as round, pale tissue. Sometimes necrotic, and usually there's minimal bleeding and drainage because at that point there's no blood getting to it. The peri-wound. If the peri-wound area, the area around the outside, is thick, shiny skin, no hair, pale limbs, that's a good sign it's an arterial wound. And then anytime that we have a decrease in pulse or an absence of pulse, that's a definite good sign that it's an arterial wound. And then temperature, because they're not getting blood flow, it's going to be cool to the touch. How do we treat it? Well, we're going to have some medications, right? We're going to have to improve the overall blood supply to start with, so they may get on something to improve blood supply, work on coagulation factors, anything like that. They may do a sympathetic block. Sometimes they'll have to do resurgery, where they may have to either revascularize the area, they may have to do angioplasty, where they put the balloon in and blow it up, or they may literally have to debride the whole area, and that area just may be gone. And then finally, obviously, last step would be amputation. So how do we treat it? Well, we modify the risk factors we can change, right? We talk to them about their diet. We talk to them about their exercise stuff. We talk to them about how to care for their skin and how to maintain their body so they don't get any further injuries. Do localized wound care, lotion to intact skin, so that barrier protectant, maybe even a little bit of hydrogel. Cotton spacers between the toes to keep the toes apart. Debridement if we need to. And then the correct topical agents and dressing choices are important. The main thing is we need to get them doing therapeutic exercise, but we need to get them with therapeutic exercise with protective techniques. So they can't be maybe walking if their heel's got that huge arterial pressure injury, can't be walking on. We got to find a way to do therax without it. And also, we're not going to do any compression with these patients. Okay, so this patient, we're not going to put compressive garments on or anything to that effect. So here's some common pictures of them. They all look beautiful. Should have warned you before I flipped slides, but that's half the fun in this. Venous wounds. Typically, venous wounds are going to be sustained venous hypertension, so they're going to have high blood pressure. So first of all, the veins get increased blood pressure. That causes their valves to become less patent and less functional, and then that stops the pump. Calf muscle pump failure, meaning they're just not moving around as much, right? Trauma or DVTs can cause it again. We always want to be aware if the patient's at risk for clots. Previous venous insufficiency ulcer. So if they've had a previous ulcer, they're more at risk to get another ulcer. So we have to be paying attention to that. Advanced age. Any type of patient, once they get older, they put themselves at risk for both arterial and venous insufficiency ulcers. So we've got to be careful with that. So how do we measure for venous insufficiency? Well, the gold standard is the venogram, where they're actually going to go down and do checks on it. You can do ultrasound on it. The ABI also works, and then venous filling time test also work. So for this one, again, the 5PT method for venous wounds, again, pain, adult ache or heaviness. Typically when I've seen a patient's got a venous wound, the one thing they talk about is the leg just feels heavy. Usually in the medial aspect of the lower leg, so malleolus, so again, different than the lateral aspect for the arterial. It's usually going to present with a superficial, irregular shaped wound. So it's not going to look like a good circle. It's going to be kind of odd shaped and irregular. Usually moderate to high drainage, so there's a lot of seepage usually from these wounds. And usually starts with beefy red tissue, and then it'll go to kind of a ruddy brown appearance. The peri-wound area is going to have dermatitis, meaning it's going to be flaky and kind of chalky. It may develop cellulitis later in time period. Edema, it's going to be erythemic, so bright red. And then it'll eventually go dark pigmented skin as it's dying off. The pulses, usually the pulses are going to be normal and present because this isn't an arterial problem, this is a venous problem. And you may notice a small increase in temperature. A little too fast there. Gold standard for treating this patient is compression therapy, and contraindicated with ABI higher than 0.8, so we have to pay attention to that. Localized wound care to absorb the drainage, protecting your skin, enhancing the venous return, and therapeutic exercise, obviously. So here's some beautiful pictures of some venous insufficiency ulcers. Tasty. So here's the common kind of breakdown of them, right? So you can see that with arterial, very painful. Venous, maybe not as much. Position, it's a little different. Presentations are very different. And then same thing with the peri-wound area being very different. Pulses, that's the key thing. If you can find a diminished pulse, you're looking arterial, not venous. So I'll leave these links on there. It talks about the Uniboot, the Pro4 compression system. Please look at them. They won't be specifically on your test, but go ahead and take a look at those links for me. So compression stockings, right? These are in order to improve the overall venous return. Usually up to 40 millimeters of mercury, so about half of normal blood pressure. And the idea there is, if we can bring it down 40 millimeters, maybe we get it closer to normal blood pressure. They can be very difficult to don off, so they're a pain in the butt to get on and off. And we have to keep constant girth measurements, because if they start maybe losing some of that swelling in that area, then the stockings may no longer be effective. All right, let's take a quick look. A 50-year-old woman presents with edematous lower extremity medial lower leg wound that is moderately drainage and mildly painful. What kind of wound do you think it is? Okay, what do you think it is? So if you guess venous, you're correct. Which of the following is most likely to accurately measure a change in perfusion of the skin? Which of that's going to present with the change in perfusion of the skin? Capillary reflex test. 71-year-old patient presents with a compression bandage. She has edematous legs but currently no open wounds. She has arthritis and lives alone, but does have caregiver come twice a week. What's the best compression option for this patient? Assuming the ABIs are normal. Well, the best compression patient for this patient I would go with, right? She has edematous leg but currently no open wounds. I would probably go with daily stockings. A 7-year-old patient presents with a dry ischemic necrosis on the distal toe following failed attempt at revascularization. If we've got ischemic necrosis on a distal toe, Unfortunately, usually what they're going to look at that toe, because we've got failed revascularization. At that point, they're going to be looking for amputation. What would cause a wound on the medial malleolus? Which one's medial? So lateral was arterial, right? Medial is typically venous. All right. Which of the following also is characterized by a small round lesion, usually on the toes or distal foot, right? Arterial are usually on those. Patient has completed a venous filling test. Was noted that the time for superficial wounds in vein is to refill of 20 seconds, right? Normal is that. So if we're doing time for the superficial veins, we're talking venous insufficiency. All right. Go ahead and look through those. Here's how we calculate the ABI, which is what they were talking about. So they're going to take highest pressure on the right foot versus highest pressure on both arms, and that will compare the overall, what they call ankle brachial index. And anytime we end up with changes that were greater than 1.4, we get claudication or problem with the vessel hardening. And then if you look down, normal is 1 to 1.4, so they should be about equal or a little bit higher, right? Below that is acceptable. And then if you get further down, we're going to look at moderate or maximal arterial disease. Diabetic ulcers, also neuropathic ulcers is the term. About 18.2 million patients have diabetes. It's responsible for over 60,000 amputations annually. So the diabetes is nothing to be messing around with, is what I'm saying. Risk factors: diabetic ulceration and delayed wound healing. With vascular disease, right? Elevated blood glucose can damage blood vessels. Anytime you have that sugar floating around the blood vessels, that can lead to blood vessel failure. It's the leading risk factor for coronary artery disease, right? Strokes and peripheral vascular disease. Neuropathy. Primary cause of diabetic foot ulcer development. If they can't feel their foot, they're probably going to wound it, and then they're going to end up with ulcers because of it. And have sensory and motor autonomic neuropathy as well because of that. Once they start losing sensation in that foot, everything else kind of goes with it. Abnormal foot function and inadequate footwear is often a cause of it. So maybe they've got impaired range of motion of the foot, or maybe they're just wearing bad, shoes and it's causing foot deformity, or they had foot deformity to start with. Risk factors, right? Impaired healing with immune response. Obviously, diabetes causes the immune system to kind of go out of whack. So then you're not going to heal right. That allows further problems with that wound healing. Poor vision. A lot of these patients obviously get some macular degeneration, and therefore the wound doesn't heal properly. And especially if they're not managing their glycemic control, so they're not measuring their blood sugar, it's going to impair all phases of wound healing. So what can we do? Well, we can assess pulses and capillary refill tests. Do Doppler ultrasound or the ABI. Definitely want to go ahead and measure the sensory integrity. We want to do the Semmes-Weinstein monofilament testing. That's where we take that monofilament and exert a 10-gram force on the actual skin and see if they can detect it. If they don't have that 10 gram of force sensation, unfortunately at that point, then they don't have protective sensation. And what that means is they are at a high risk then to develop a diabetic ulcer. So here's where we're going to test on the foot, right? So the plantar surface, we're going to test big toe, right? Third toe and last toe. And then we're going to test right along the bottom part of that as well in the plantar surface. And the dorsum, we're going to test right between the big and the second toe. So presentation of diabetic ulcers. Pain. Typically, they're not going to have any pain because they usually don't have sensation in that area. They're going to be on the plantar aspect of the metatarsal heads, right? So it's going to be from stepping on things. They're going to be round, punched out lesions with a rim that's going to have a callus, so it's going to have a hard area. Usually low drainage, right? And can have some eschar and necrotic tissue, right? It's not uncommon, or it is uncommon for those to be there. I'm sorry if my brain's not working right now. Peri-wound area is going to be dried, cracked skin. That means we need to take care of that peri-wound area, right? Toenails typically thickened. Again, the extra blood sugar will cause this to go along. Structural deformities. Toes will club off. Peripheral edema is really common, but that's also really common with just diabetes in general. Pulses may be normal, decreased, or accentuated. So there's not a real specific pulse hint here. And typically there is a mild increase in temperature. So how do we intervene with this? Well, it's going to take interdisciplinary approach. Patients are going to have to be seeing somebody to treat their diabetes. If they don't get their diabetes under control, we're not going to have any success in treating the wounds. We're going to have to educate them, right? They're going to have to doing foot checks regularly. Anytime they lose any sensation, either feet, their hands, or anything, they have to be checking them on a regular basis. We're going to have to learn to debride the callus, so we have to get those calluses out of the way so we get nice, soft, smooth skin. They're also going to have to moisturize daily everywhere except between the toes. Toe spacers are a good idea for these patients. Also, making sure they don't put anything between the toes, so especially lotion that's going to macerate the toes. Offloading, right? We may talk to them about, for the time being, if they've got an ulcer, keep that foot off the ground. Diabetic footwear is designed to conform to the foot deformities and have extra space. They're often they're not the most pretty shoes in the world, but they do provide them with good, good safety with them. Custom orthotics may be necessary, right? Total contact casting is the gold standard, right? We may use walking boots, splints, or walkers as well. And then I got a link there to the total compact casting as well. Therapeutic exercise, right? We're going to do range of motion exercise to start with. Aerobic exercise can help with proper glycemic control. And then gait and mobility training. That's going to be our major thing. Teaching them how to walk now with their ulcer or their injury on their foot is going to be the major thing. And then footwear modifications. Teach them to wear proper footwear. There's some diabetic ulcers. So here's a comparison between arterial and diabetic. You guys can look at that on your free time, right? Burns. This is the bad one. I'm going to warn you about these. 2 million burn injuries each year. About a third of those are children, and out of those, 10 to 30% of those are, child abuse. Most occur in the home, and that kind of makes sense. Because where do we get most of our burns, right? We get most of our burns at home. Most are preventable. And even you guys, if you talk to yourself and think about it, any burn that you've had is probably preventable. Types of burns, thermal is the most common, right? This is direct contact with flame, hot liquid, or steam. It's 80% of all burn unit admits. Contact time, temperature, and severe or type of injury insult is usually going to determine severities, right? So if you just get a little bit of boiling water on your skin, you may have a burn, but it might be localized to a really small area. Whereas if you dump, a whole bucket of boiling hot water on it, it's a little different type of burn. Chemical burns are kind of to me, they're the worst ones next to electrical. Strong acids or bases react to the skin. The burning continues until chemical is removed or diluted. And sometimes with these chemical burns, patients will go ahead and toss water on it, and that can make the burn actually worse, right? A lot of times baking powders or baking soda is what's going to be used to kind of stop that chemical burn. Electrical, charred entrance wound, and explosive exit wound. These have high mortality rates. When the electricity goes in, it has to come out somewhere. And usually where it goes out is not a pretty area. And the mechanical, the main cause is friction, right? Rug burn, rope rash, road rash, any of that is the typical mechanical burn, right? I see it a lot when I was back in Pennsylvania with motorcycle accidents where the patient may have slid 30 to 40 feet on the road. So here's some beautiful burns, right? So we got the top one's probably a water burn, right? You can see the chemical burn. There's the rope burn. And then that one to the bottom left is definitely 100% electrical burn. That's where the electricity left the hand. I wanted to warn you about that, but classified historically by degrees, right? First degree, second degree, blah, blah, blah. We're now classifying them just like wounds. Superficial partial thickness, deep partial thickness, full thickness, and then subdermal. So remember this, rule of nines. You need to know this for your boards. This has got to be beaten into your head. They will ask questions about this. I guarantee it. So don't skimp on this, right? Remember that all of this is different. Obviously, everyone seems to remember the peri area percentage, but you have to know all of it. What happens with burns? Well, the skin system gets compromised, right? What about cardiovascular? Well, can cardiovascular get compromised as well? If cardiovascular and skin systems are compromised, especially if it's on the chest, pulmonary system will become compromised. They'll go into this chronic inflammation cycle, so their immune system goes out of whack. And then eventually they can go into organ failure, CNS dysfunction, and even GI dysfunction because of this. So prevention or precautions. We want to screen for domestic violence. If you suspect that a patient is a victim of domestic violence, please inform your PT. You don't have to always ask about domestic violence. There's classes you can take on learning about domestic violence and how to recognize it. But if you suspect it, please let your PT know. Fluid resuscitation. These patients are often, when they first come in with the burn, are going to be put on high amounts of IV fluid in order to return the fluid that's lost from the burn. They're also going to have localized wound care. We're going to debride it and then control the infection. Dressings. Often we're going to use impregnated gauze, so that Zeroform, but large sheets of Zeroform with bulky gauze dressings over the top, and then Sylvine in adjunction with it. Adjunctive modalities, Whirlpool's really common actually. Hover tank and Whirlpool are very common to get the dead skin off of it. Scar management is going to be really important after we get to the scar point, right? They're going to need to learn how to moisturize their skin constantly. Compression garments, these are going to be custom made, not like the off-the-rack ones for Venous. They're going to be based on girth measurements. They're going to change constantly. They are expensive, so this can be a serious cost problem for some patients. And then obviously scar mobilization. With patients got a burn, we need to position them properly, right? Enhance scar healing, prevent contractures. Range of motion exercises, it should be either self-range motioning or somebody should be range of motioning them 2 times daily. Mobility, breathing, and aerobic exercises are essential. So these are some graphs going on, right? Remember, if it's an allograft or autograft, I can tell you where the skin's coming from, right? Or a xenograft. Know what those types of graphs are. Finally, we're going to finish off with lymphedema today. So lymphedema is where the lymph system regulates the fluid balance and assists with infection control. Unfortunately, that can cause when the lymph system cannot remove that excess fluid, right? Chief complaints of this, again, are heaviness of the limbs, right? So that we have to, when we have a venous problem, we have to rule out, is it venous or is it lymphedema? Paresthesias are common, and decreased function of the extremity will all be common signs of lymphedema. Primary lymphedema, this is where lymphedema is the problem, occurs with no obvious cause, only 10% of the cases. Secondary lymphedema comes with other medical problems, right? With diabetes maybe, or with a mastectomy in the case it's describing here. So primary lymphedema is the problem. Secondary lymphedema, it is secondary to something else. It's usually disruption or damage to the lymph system itself. Lymphedema secondary to venous insufficiency is also common. May masquerade as just venous insufficiency, but when we have lymphedema along it, we're going to have positive stemmer signs, confirms lymphedema, where you pinch the second toe and it's extremely painful. So integumentary changes, well, we can get with pitting edema. Pitting edema is edema where if you press down on it, it doesn't return to normal shape. The skin will harden and thicken. It will weep. I've had patients where we've gotten a small, what we'd consider a paper cut that has weeped for hours, right? Skin folds, right? Obviously, we got to worry about stuff like pannuses and stuff like that if we have patients that have that. Papillomas are common, and dermatitis, especially any contact with anything that might be irritating, is often cause for contact dermatitis. Wound characteristics, ulcerations from traumatic injury or pressure, right? Maceration occur within folds, so the longer those folds fold over each other, the more likely to develop macerations between those folds. The ulcers are shallow and may be oozing, moist, or blistered, most commonly in the arms and legs, and we have to follow localized wound care. So we'll just treat what we see. So multi-layered compression wraps are best for this, and that's after we've already done lymphatic drainage. So we're going to want to do manual lymphatic drainage, right? Or what we call CDT. That's usually done by a lymphedema specialist. But following that CDT and that lymphatic drainage, we've got to get them on low stretch bandages, right? In order to keep that fluid from returning. Because if we work the fluid out of the leg and then do nothing to maintain that patency of those lymph system with pressure, all that's going to happen is going to go right back down to that leg again. Other miscellaneous wounds you can count, abrasions, right? We all get those. Skin tears, surgical wounds, right? Any type of an opening for the wound. Anytime we open the body, right, we run a risk of re-injuring the body, and so surgical wounds are really common. Fistulas, right? Abnormal connection between organs, vessels, or intestines, right? Anytime that we have a hole going somewhere that we're not supposed to have a hole is a fistula. Compartment syndrome. These patients that have compartment syndrome just I feel pity for them. I really do, because it's just not something that's fun. Traumatic wounds, bites are common, right? Especially, people that have dogs, cats, anything like that. Any type of animal, tigers evidently. But bites are pretty common. And then radiation wounds. We don't see it as much here, but we did see it a lot in Pennsylvania because we had 3 nuclear plants within a few miles of actually most of my clinics. So all of that's pretty common.